last semester's ASRT videos were pretty comprehensive, so we're not going to cover image acquisition, CR and DR as in depth as what we saw it last semester, so this will mainly be a review. So remembering that we've got two different technologies, one of which you probably don't work with much, if at all, being computer radiography. Everything is going towards digital. Medicaid, Medicare reimbursement prefers digital radiography over computer radiography, so your hospitals are making the transition or have made the transition primarily to digital imaging as opposed to computed radiography. Computed radiography is still on the registry, so we'll talk about it. And the technology for computed radiography was more similar to screens and films. So when we made that conversion from screens and films to a digital type image capture, the most logical and most economical first step was to change to computed radiography before digital. So CR, if you see a question about computer radiography, it'll just be abbreviated CR. Most of the, and that's for our purposes, most of the industry standards are just kind of making a shift to lump them all together into digital, but that's our way of identifying the different technologies. So CR involved imaging plates inside of cassettes, and they looked a lot like screens and film technology. So the benefit of changing to CR before DR was that the processor was replaced with the CR reader, and the cassettes with the films inside were replaced with a CR cassette with the imaging plate inside. So really fundamentally the only thing that we had to change was our techniques, one, and two was to replace the film processor with effectively what we would call the imaging plate processor or the imaging plate reader. So we had a couple of different types of imaging plates. One involved needle phosphors, and needle phosphors, I think I demonstrated this at some point during the curriculum. The needle phosphors are cylindrical phosphors, so they're individual phosphors that have depth to them. So the more radiation they absorb, the more energy they absorb, and the more signal basically that they absorb. The artifact specific to needle phosphors that we identify is that whenever some of those needle phosphors, one or more of those needle phosphors stop working, we have what we call a dropout artifact. Since the needle phosphors are side by side, and they occupy space all the way through the phosphor layer, when one doesn't work, then that gives us an artifact that we call a dropout artifact, and it just looks like a place where you had absolutely no exposure. So it's just a single small vacancy in your image is what a dropout phosphor is, and it's very specific to the needle phosphors. As opposed to an emulsion layer, essentially, where you had phosphors stacked on top of each other. They're more like individual little bitty plates that are stacked on top of each other in a layer more similar to what we call a film emulsion. Those also trap signal. They trap a portion of the energy that's converted from X-rays in the signal. And the more energy they trap, the more of a response that they'll get in the reading process. We'll talk about here in a bit. So it's very similar to a film emulsion. It's a lot of different layers. If one individual phosphor doesn't work, then you might have a little bit of a loss of density in a specific area, but it's not going to be as noticeable as what it would be with needle phosphors. So I think the demonstration I used in class was to pick up just a load of pins all in one big group. So you got all these pins so that you can see the whole pin. But if I could pull one directly out of the middle, what you would have is just a vacancy there, and that the needle phosphors were represented by the all of the pins together, and then a dropout phosphor would be represented by one pin missing from this wad of pins. So we'll make an exposure on the plates, and the cassette is really just a stable platform and a stable protectant for the plate itself. It opens up, you can pull the plate out. So we'll make an exposure on the plate inside of the cassette, and we feed that into a reader. The reader opens that cassette and it removes the plate, and it runs the plate through the read process. So what happens, if you remember, you've got two different scan levels. In both cases, what you've got is a laser that scans across it. So you got a fast scan and a slow scan. And the slow scan is nothing but the travel of the plate. So the plate travels through the reader, kind of like on a conveyor belt. But the fast scan is really what's going on with the read itself. So you got this laser that pivots and it scans across the face of the plate. If you remember, you have to have light focusing optics to keep the size of the laser beam consistent between one side of the plate and the other. Otherwise, what you do is the laser stimulates those phosphors, and because of the divergence of the light field from the laser, as it pivots, what you would have is on one end of the plate, you would have a larger light field stimulating more phosphors, and it will give you an even density across the image. So light focusing optics, pivoting laser, and fast scan while the imaging plate travels through the reader on a slow scan. And the purpose for the laser is to release that energy that's stored up. So you've got two different things going on at the same time. You've got the laser stimulation, but you've also got the light detection. The detection of the light and the amount of energy that the phosphors absorb determines how much light is left or released from those individual phosphors. So bright laser releasing a lot of energy that's focused to the size of the phosphors themselves. At the same time, you've got light detection, and that light detection picks up the light that's coming off of those phosphors, puts it into a photomultiplier tube, and eventually into an analog to digital converter to digitize the image and send that image to the workstation. Even though the laser is very intense and it releases most of the light from the plate, some of that energy is still trapped inside those phosphors. So we have to get rid of those. If we don't get rid of those, then what we have is effectively a double exposure the next time we use those plates. There will still be an image on that plate itself. So we put it through an eraser bank. And the eraser bank is just a lot of fluorescent light bulbs that shine very intensely on the plate to release the rest of the stored image. If you remember, we had such a thing as ghost imaging. So ghost imaging was where our eraser bank was not adequately bright to release enough of that trapped energy inside of those phosphors to prevent us from having a residual image from previous exposure. So again, we would basically have a double exposure going on there. DR systems are referred to as cassetteless. And it's not that you don't have a cassette, it's that you don't have a cassette that you have to remove and put it into a reader. The cassette is hardwired into the system, or if it can be removed, it's removed for different applications like tabletop exams. So the cassette is still there. There is a cassette, that is your image receptor, but it's totally different than screen films and CR systems. So you got a couple of different things, a couple of different types of DR systems. Regardless of what type you have, what you've got are detectors that are hardwired into the system. So you have thin film transistors, if you remember, and they detect electrons liberated by the remnant X-ray beam. The remnant X-ray beam is the secondary beam post-patient. But of course, if you have an uncollimated portion of your X-ray beam striking the image receptor, the same thing applies there. So in both CR and DR, what you have is a different sensitivity to radiation exposure. Whenever we first made the change to CR, the techniques or the sensitivity of the exposure to the CR cassettes and CR plates was lower than what it was with screens and films. So when we made the change from screens and films to CR, what we had to do was we had to adjust our technique, and we had to increase our technique actually. The CR plates and readers and detection processing system was about half as fast as what it was with screens and films. Most of the time we were using 400 speed screens and films, and whenever we made the change to CR, the relative speed and sensitivity was 200, so we had to double our technique. Once we made the change to DR system, DR is much more similar to in sensitivity to screens and films than what CR was. So our techniques in DR are more similar to our screens and films, with this one difference. When we made the change from screens and films to CR, what we had was an ability to change our technique and adjust our technique in a non-traditional way. Previously, whenever we changed from a 400 speed system to 200 speed system, what we would have to do is double the mass. But because CR manipulates contrast and density, KVP becomes less of a direct control of contrast and more of an influencer of contrast in a CR and a DR system than what it is in a screens and film system. So I say that to say this: whenever we change from screens and films to CR, we required an increase in technique. If we'd increased our mass by a factor of 2, our patient dose would have gone up by a factor of 2. But what they did instead is they used KVP, an increase in KVP instead of an increase in mass. So on a hand, in a screen and film world where we might have used 50 KVP for hands and fingers, let's say, in a digital world, in a CR world, we could increase to 55. And therefore we increase our exposure without totally doubling the patient exposure. So we increase the amount of radiation, the output from the tube, without doubling the exposure. So we increase KVP to affect the same change in exposure to the image receptor without doubling patient dose. Patient dose did go up, but not quite as dramatically as what it would have with just doubling the mass. Once we made the switch to DR, then we could decrease our mass. The KVP didn't go back down, but we decreased the mass, and patient dose truly went down. So some people will say, well, technique selection is not as important in a digital world as what it was in screens and films, and that's not true. It's every bit as important for a radiation exposure, and then secondarily, it's as important for imaging. So slight overexposure, underexposure is not as big of a deal on CR and DR as what it used to be with screens and films, but it's still important to get your technique right. And certainly, as far as overexposing, technologists in the early implementation of CR had a tendency to um, make exposures with too much technique in order to prevent having too little technique and underexposing the patient. Underexposure might have meant a repeat, whereas overexposure meant you could just process that out. That led to an ethical situation or an ethical problem that we had to face, and it was called dose creep. People got lazy, they got unprofessional, and instead of learning their techniques, they just shot everybody with way too much radiation. So in addition to selecting the right technique, you also have to select the proper exam, so that whenever you set up your control panel, if you tell your computer, especially in a digital application in the DR world, if you tell your computer that you're shooting a set of ribs, and you set a technique that is more for a chest x-ray, and you just got lazy and you selected something that looked like thoracic viscera, and it turns out it's ribs. If you wanted to see chest x-ray, you're still going to see ribs. So it's important to select the right exam in DR so that it can apply the proper lookup table. Remember, your lookup table is your stored computer algorithm. So that if you tell the machine that you want to see ribs, it's going to show you ribs, regardless of what your technique looks like. So centering is important. Collimation is important, especially in some CR machines. If your collimated border does not make sense to the CR unit, then you're going to have some automatic rescaling issues. And what I mean by that is if you try to collimate on, let's say, a forearm, and it shows you you show the machine a collimated border that's going maybe at 30 degrees across the image receptor, and your collimation is cut off on two sides by the edge of the cassette. There's no way that in the setup of that algorithm they could have possibly imagined that you would do that. So what your resulting image is going to come out looking like is some weird collimation and a totally dark image. It may be totally black and you may not be able to see anything. So it couldn't really make sense of what you were doing. So it kind of freaked it out, and you got an automatic rescaling error. CR only issues, we have certain issues just related to CR. So image size may affect sharpness of reported detail in the CR cassettes or CR plates. So some of your manufacturers made their plates based on one image matrix size or one CR matrix size. So let's say you've got needle phosphors and you've got an image matrix that is 1,000 in one dimension and 800 in the other. And that's on an image receptor that may be 10 by 12, 10 by 12, 10 inches by 12 inches. They would use that same matrix size for all image receptor sizes. So if you change that image receptor size to a 14 by 17, and you've got that same matrix size, 1,000 by 800, then what has to happen in order to fill up that new image receptor size, that larger image receptor, is those individual phosphors have to be larger. As a result, you have less sharpness of recorded detail, lower resolution with larger image receptors. Since you cannot make multiple exposures on a single image receptor on a DR system, multiple images on it are is really only a computed radiography issue. But what we can do is mask off one portion of the image and make an exposure, and then put the opposing view, let's say you're doing a hand, put the opposing view on the portion that was previously masked. And by masking, what I'm talking about in this case is a lead absorber or lead apron or something to block X-ray images, or X-rays, scatter X-rays from striking that portion of the image receptor. We could put multiple images on the same image receptor before processing the image. Specific to CR systems. The problem that we run into with multiple images on a single image receptor is that they are susceptible to scatter radiation from other projections, and also, again, back to the collimated, system being able to make sense of what your collimation looks like. If you've got them on the image receptor and the system can't make sense of the collimated area maybe being non-parallel, or the collimated borders being projected off of the image receptor, the machine in a lot of cases can't make sense of that. So that would be susceptibility to scatter from other projections plus your collimation together. You may have not only some fog issues, but also you may have some histogram analysis failure there as well. We're also sensitive to fluorescent light and background radiation. If you haven't made an exposure on a CR cassette in a number of hours, then you really need to erase that cassette. Just send it to the reader, and you can just select the eraser portion of the read and just have the plate re-erased. And also, along with that, the latent image on the image receptor is only good for a certain period of time as well. So if you have a number of x-rays that you have to take portably up in the patient's rooms, in different rooms on the floor, and you don't read that image, you don't have that image lifted off that plate in a timely fashion, it starts to fade. So there's a time element there as well. After you make your exposure, you need to get it read as soon as possible. So exposure field recognition, we talked about that. You need equal collimation for the most part. Histogram information. The histogram is the stored, well, there's two histograms really. There's the stored histogram, which is your lookup table, and then there is your histogram that you make whenever you make an exposure. So when you make an exposure, the range of exposures that are represented on your image receptor form your histogram. So it's represented by the number of detectors exposed and the energy that's imparted to those individual detectors. So if you increase your KVP or you increase your mass, you get more energy imparted to those detectors, and that's representative of a higher exposure. So where you have long spikes in your histogram, if you can get into the system and look at your histogram, what that represents is very high exposure. So you may have background x-rays, direct exposure to the image receptor, whereas the low spikes are representative of a lot of radiation absorption before it strikes the image receptor. So again, if your computer can't really make any kind of sense out of what you did, and it can't match up your histogram closely with the stored histogram or lookup table, then what you get is a histogram analysis failure. So image receptor exposure is your exposure index, and it varies according to manufacturer. Some of your manufacturers use an escalating scale, some a scale that is inversely proportional to exposure, and some use numbers like 200 to 400, some use numbers like 1 to 5. So you got to know what your manufacturer, what they represent as their image, their index number exposure, and what it means. So what it tells you is over exposure, under exposure, proper exposure. The problem that we get into with just using the exposure index as a indication of whether or not we've got adequate exposure is that going back here, if you have an exposure and your histogram represents a lot of direct exposure to the image receptor, that is going to skew your histogram, or I'm sorry, it's going to skew your index number. So if, let's say, you shot a hand, and your hand, you didn't collimate very tightly, and you got a lot of direct exposure to your image receptor, then your machine can't really detect where the edge of the soft tissue was. It can detect it and it can present it as an image, but it doesn't really know what the edge of the anatomy looks like. So you may get a index number that indicates that you well overexposed the patient when in fact you did not. You could use too little radiation with too big of a collimated field and it would represent a high index number. So collimation becomes very important in CR and especially DR systems, and not for the reasons that we talked about really in the first and second semester, or even third semester. So it goes into your image receptor exposure index number. So in image analysis, what you need to look for is a lot of different things. How much collimation did you have? Is the centering right? Is the collimation, should the collimation make sense? Did you collimate your collimated area? Was it represented angular on the image receptor when you were shooting a KUV? Did you have a lot of direct exposure? Take a look at your index number, take a look at your collimation, take a look at your exposure factors. It has to be a more holistic observation than what it used to be with screens and films. With screens and films, if the image was too light, you needed more radiation. If it was too dark, you needed less radiation. So in image analysis with CR and DR systems, you have to look at more stuff than just how dark the image was. Again, a histogram is a graphic representation of the exposures that you made and how much radiation that image receptor received. So it's determined by the exposure. The role of KVP and the role of mass still are the same as what they were with screens and films. The higher the KVP, the more penetration you get, and the quicker the image receptor will receive enough radiation to make a logical image. With mass, it's just a numbers thing. If you double your image receptor exposure, or you double your exposure, double your mass, you double the image receptor exposure. So histograms may look like that. Very high exposure, very low exposure across the image. These things just don't make any real sense to us. So what we use to represent a histogram, stored histogram, is H and D curve. And you can see that superimposed here. So if we have a very vertical H and D curve, that represents a histogram that's very high contrast, as opposed to, let's say, a chest X-ray histogram would be much more horizontal. So the lookup table is a stored ideal histogram. Whenever a hospital gets a new system, then the radiologist will sit down, usually with maybe a couple of radiologists, with the applications tech and maybe one of the lead technologists, and look at ideal images of every body part. So they may look at 5 different hands and say, yeah, I like hand number 2. And then they look at 5 different chest x-rays and say, I like chest x-ray number 3. Those chest x-rays and the histograms that are associated with those become the lookup table for each one of those exams. So that's going to be the exam, or the image that every exam of that type gets compared against. So rescaling is the attempt to make your histogram look like the lookup table. It's done automatically and is referred to as automatic rescaling. So mispositioning of the histogram causes reader error. So if you have a patient who has, let's say, a hip prosthesis, your computer has a hard time making sense of that. Because on your histogram, what you would have is large areas with very, very low density, very low exposure to the image receptor. So if you have misaligned collimation, then it can't make sense of that. In some cases, usually that's a CR issue. If you have poor positioning so that your histogram is looking for density in the center of the image and your density is off to the side, you may have a tough time making sense of that image. And inappropriate selection of the exam. So if you take this histogram, which is really pretty high contrast, so maybe these ribs, and you tell it that you want to see a chest x-ray, it's going to show you the chest x-ray. So it's going to apply a different histogram to what it is that you are wanting to see. And so it's not really truly a histogram error there. It's showing you what you tell it wants to show you, even though your technique was completely inappropriate. So excessive scatter radiation, background fog, all of those can affect your automatic rescaling. So again, automatic rescaling is comparing the histogram to the lookup table, and if any of that stuff is inaccurate, then you may have a histogram automatic rescaling error. The lookup table is the ideal histogram as compared to an H&D curve. So, and that's just so that we can kind of make sense of what the histogram looks like. Again, we've really already talked about all of this. The things that can cause histogram analysis error would be field size, positioning, presence of metal, all of those things. Part selection, off-centering, collimation. So if you have underexposure and your collimation is accurate and your positioning is accurate, then what you may observe is your exposure index number is off, and in some of the machines, underexposure is going to be represented by a high index number. So there's an inverse relationship between the index number and the actual exposure. But if everything else is right and your exposure index number indicates that you have underexposure, then what you actually may have is a loss of contrast, which in a digital world that's confusing because we've been talking about overexposure to the point of reaching the shoulder portion of the H&D curve, giving us a loss of contrast, but really, and then mass controlling our contrast, or I'm sorry, KVP controlling our contrast. In a digital world, really underexposure being reflective of mass can cause a loss of contrast as well. So that's kind of confusing. Overexposure requires a little bit more analysis. So if you have overexposure because your KVP is too high, you may see a loss of contrast from increased scatter radiation and increased penetration. Or if your KVP is too low but your mass is too high, then what you may see is a loss of contrast and density, both, even though your index number is too indicated overexposure. So adjusting technique, always use adequate KVP. Know what your adequate KVPs mean. Chest x-ray 110 to 120 KVP. Check your technique prior to to make it a repeat. Check the index number against the image appearance. So if you have a loss of contrast, then was your KVP too high? Was your KVP too low? In both cases, it could cause a loss of contrast. Did you have quantum model present? Was your mass? You should be developing a feeling for what mass, a range for what mass should look like on an individual patient. Was your mass, whenever you shot, was it too high or too low? Collimated borders, how did they look? Did you have direct exposure to your image receptor? So a lot of things to consider. So how do you correct your exposure? Well, if penetration is the problem and you can identify that, then you're going to utilize the 15% rule. So your exposure index number was okay and everything else was adequate. But what it seemed like you had was a lack of penetration. Then you would increase your KVP and decrease your mass. When mass is the problem, then you're just going to use a change in mass. If everything else is good, you use good KVP, collimation is good, positioning is good, but maybe you have quantum model present, then you're going to use a change in mass. Keep in mind you can use the 15% rule here as well. What you would be doing in this case is reducing your KVP and increasing your mass to get rid of that quantum model, providing everything else is good. You just needed more radiation exposure to the image receptor. So other issues, scatter, both scatter inside and outside of the collimated field. So scatter inside the collimated field, really the ways that you would affect that is introduce or reduce the amount of scatter inside the collimated field. Is introduce a grid, or if you wanted to make an adjustment to your technique, you could reduce KVP and increase mass. Keep in mind that grid use is going to change your histogram. So you may introduce some histogram analysis issues. Keep in mind that SID changes also in change intensity. So if you increase your SID from 40 to 72 inches, the intensity strike in the image receptor is going to be reduced by a factor of 3.24. OID changes also in change intensity, and since they change intensity, you need to adjust your mass accordingly. What you have going on there is air gap. So it changes intensity, and it's also going to change your histogram as well, slightly. Maybe not perceptible to your eye, but it will change the detection of radiation and the intensity across the image and change contrast. Anode Hill effect changes intensity across the image receptor. Make sure you utilize anode Hill effect properly. Put the thickest portion of the anatomy over the anode end of the X-ray tube, or under the anode end of the X-ray tube. So patient conditions and presence of metal. We talked about presence of metal, but also if we have a patient who has let's say a massive pleural effusion, that's going to change the representation and the similarity between your histogram and the lookup table as well. So how do you affect a change in scatter? Well, we talked about grid use, you know about proper KVP. Use collimation, use grids where appropriate, use lead shields whenever you're shooting through very large anatomy, like lateral T-spine, lateral L-spine, things like that. So grids, the reason they change your histogram is because they absorb X-rays of all types, but they absorb primarily scatter radiation. So they're going to increase the differences between the highs and the lows on your histogram. So we need to compensate for grid use with mass, with SID. We also need to compensate with mass. With the direct square law and the inverse square law is But just to review, the inverse square law is change in intensity as opposed to the direct square law is technique compensation, changes in distance. OID, again, is your air gap. Compensate for that with mass. Collimation, if you change collimation, you increase your collimation, which means to make your field size smaller, then again, your technique correction is going to be mass. There's no technique correction for anode heel effect. Just make sure that you use it properly. Keep in mind with your pathology, you've got two different types of pathology. You've got additive and you got destructive pathology. And additive pathology is anything that increases the perceived patient atomic number. So it adds density to the anatomy, whereas a destructive pathology removes it. So an additive pathology would be something like a pleural effusion. The lung doesn't really increase its atomic number, but it's full of fluid, which has a higher atomic number. And then destructive would be the exact opposite of that. So a destructive lung pathology would be something like a emphysema or a pneumothorax. So AEC use, very important to properly position with AECs. Positioning and collimation both become absolutely important. Make sure you select the proper or a good KVP. Make sure that you've got plenty of backup time. Your machine should be set up so that for an exam type, it should have plenty of backup time. Select the detectors that will be covered by the area of interest. If you've got, let's say, the outer two cells activated for a lateral chest x-ray, you may get direct exposure to the AEC, which would shut off your exposure too quickly. So make sure that the anatomy fully covers the AEC. If you're making an exposure on a small anatomy that's difficult to cover the entire AEC, then you might consider using your density controls. Hit it with a +1, +2, things like that. And an example of that would be if you're shooting a humerus. If you're shooting a humerus, sometimes it's difficult to get that entire AEC covered. And again, cannot stress enough the importance of collimation. In correcting images, you're going to analyze for technique, collimation, grid use. The proper use of each one of those is still in play here. Make sure that you've got a properly positioned and aligned X-ray tube and anatomy, and X-ray tube to the image receptor and anatomy to the image receptor as well. Keep in mind that any kind of adjustments that you need to make for bad positioning are half of what you see, and we kind of walked through that last week. If you have an image that's poorly phototimed, it could be because you've got bad positioning. It could be because the anatomy is not reflective of what normal anatomy should look like. Again, a pleural effusion might throw your index number off a bit. And certainly if you have metal directly over the phototimer, what you're going to have there is gross overexposure if you've got metal completely covering the phototimer. Again, collimate, control scatter radiation, but it also helps to influence your histogram and its relationship to the lookup table. But in exposure itself, it ensures proper exposure through the region of interest. If you're taking an X-ray of the L-spine and you open up your collimation as if you're shooting a KUB, then that's going to affect the image and the appearance of the L-spine itself. So don't try to phototime through a prosthesis. Set a technique if you can. Use your density controls where appropriate. You might have to use a +1 or a +2 if you've got relatively small bone that you're trying to put over a AEC. And pay attention to your mass readouts. You know when something goes drastically wrong. If you're shooting a KUB on a patient and it's average size patient and it gives you 120 mass, something's not right there. It very well could be that you just didn't align your image receptor in your X-ray tube. You forgot to move the bucky, whatever. So pay attention to what your mass readouts look like. You need to be doing that now anyway. As soon as you became second-year students, your checkoffs are dependent on whether or not you can set an adequate mass. So again, in pathologies, we've got additive conditions, we've got destructive conditions. Additive conditions add subject density, and typically we're going to change our mass by 35 to 50%, but there are times that it's appropriate to use an increase in kVp by 8 to 10 kVp. The times that we would use kVp is if the condition truly added such an increase in effective atomic number that it would be difficult to otherwise penetrate. So you know what osteoporosis is. Osteoporosis is a loss of bone tissue. That would be a destructive condition. But osteopetrosis is an increase in bony tissue. And for something like osteopetrosis, you may have to increase your kVp instead of your mass. So in image manipulation display, you got a lot of things to consider as well. The depth of the image and the amount of grayscale, the number of grayscales that your monitor will display is probably going to be significantly lower than the radiologist. In addition, your image matrix is going to be a lot larger, or the pixels are going to be a lot larger. The image matrix is going to be a lot smaller. So keep in mind that whatever you see on your image display in the light room, at the workstation, or in the patient's room in the X-ray room, is not going to be the same as what the radiologist sees. So what you're going to have to do is you're going to have to look at your image for these telltale indicators that we were talking about before. Is your S number right? Is your collimation right? Is your positioning right? Did you do everything properly? Is your technique representative of what that patient should have been exposed to? And if your image still doesn't look right, that doesn't mean it's not going to look right on the radiologist monitor. So image manipulation, you can window width and window level. Window width is your contrast, window level is your brightness. And that is what you call post-processing. And it changes the dynamic range of the contrast and the density of the image. But the important thing here is that original image needs to be what is sent to the radiologist. So you don't post-process the image, save the processed, and then save what you did and send that to the radiologist. What you want to send is the original image. If you want to post-process and make it look better on your monitor and then send that too, that's fine. There are very few radiologists that are going to complain about one too many images on the rare occasion. Now, if you do that with every single image that you shoot, where you send what looks good to you and what should look good to them, yeah, they're probably going to complain about that. But once in a while, if you adjust an image and you save your original, make a copy of the original, and post-process it, send them both. The radiologist can never process your processing back out to get to the point where they see their original image. they need to see the original. So don't save changes and then send the changes unless you send it with the original as well. So annotation versus positioning markers. Position markers are what you should be putting on the image receptor whenever you make an exposure. Your annotated markers are not legal documents. It doesn't make the X-ray a legal document. So annotated markers, if you've gotten used to just using the annotated markers as opposed to your positioning markers, that's a trend you need to reverse. You need to go back to using your positioning markers. Shuttering is not collimation, and it should only match the collimated borders. Actually, it should be slightly past the collimated borders so that you can show that you actually collimated. If you shutter past your collimated area, then you can lose some diagnostic information, so you don't want to do that. Contrast, again, is your dynamic range. That is your contrast. Your dynamic range and contrast, same thing. It's measured by bit capacity. Is determined primarily by the lookup table. Your lookup table is the main thing that controls your contrast. Collimation, grid use, KVP can influence it, but the main thing that controls your contrast in a digital world is your lookup table. And what can influence that and how your lookup table applies contrast to your image is your positioning, your collimation, your technique. So contrast resolution, remember contrast means difference. So the higher the difference and the more obvious the difference in your densities are, the more contrast you have. So more black and white means more contrast. Contrast resolution is greater in DR systems, and it's determined by the subject contrast in the remnant beam. So the subject contrast, the range of densities on the image receptor fed into and manipulated by your lookup table is what gives you image contrast. So bit depth is the number of gray values that can be displayed. So the human eye can see about 32, and a good digital system can see about 16,000, or display about 16,000. Your recorded detail is still controlled by you, by your focal spot size, but in the image receptor and image display, it's all about the image matrix. So you got individual pixel sizes or detector sizes in your image receptor. In a CR system, remember you've also got the size of the laser beam that controls or influences your recorded detail. And then you've got display as well. So you don't work with a high resolution monitor, radiologist does. So you've got recorded detail. It's not really recorded detail, it's displayed detail in your monitor size or monitor resolution. But still, smaller image receptors in a CR system give you better resolution, but that's specific to CR systems. I kind of feel like we're beating a dead horse at this point. We already talked about windowing. You got window level, you got window width. Window width we talked about. Window level is just brightness. Over and under exposure can be displayed in your index number, but also you would need to look for quantum model as well, loss of contrast, those sort of things. So artifacts, you've got internal and external artifacts. In the anatomy, you've got superimposition, which we don't really think of as being an artifact, but it is if it blocks the image or the appearance of the anatomy that we want to see. So external artifacts would be things like I don't know, bra snaps, things like that, buttons. So keep in mind that in a digital world, pretty much everything shows up. Thicker material, the difference between material thicknesses. If you've got a patient who's wearing elastic, thick elastic, it's going to show up. So it's best to just go ahead and dress your patient for most of your exams. Grid cutoff is an artifact. Inverted grid is an artifact, or inverted image receptor can put an artifact on your image receptor or on your image. Noise is an artifact, all different types of noises. A lacing or moire artifact, if you remember, that those were those squiggly lines that you get because of the similarity between the scan pattern in the CR system and grids that have a grid frequency similar to that scan pattern. And how we overcame the moire artifact is that we utilized a grid with a higher frequency, maintaining the same grid ratio, and made it thinner, but made the interspace area in between each grid strip half as wide. So we got a increase in grid ratio, or increase in grid frequency without the increase in grid ratio. So CR issues, we talked about incomplete erasers earlier. We talked about dropout artifacts, reader issues. We could have dust on the lens. Focusing optics could be dusty or inadequate. We talked about dropout artifact again. So patient positioning, maintain perpendicularity where you can, parallel relationships where applicable. So perpendicularity between your central ray and your image receptor, central ray and your anatomy, parallel the anatomy with the image receptor. Mispositioning, keep in mind, can close joints. It can cause unnecessary superimposition or distort the image through generally foreshortening. With a mispositioning of the central ray, we may see elongation, but there are times to have mispositioning of the anatomy, or more commonly mispositioning of the central ray, angulation and whatnot. So know the degrees and direction of obliquity, know the degrees and direction of central ray changes. Keep in mind on pediatric patients, they're pretty unpredictable, so we want to make sure that we keep our exposure time as short as possible. It may be more difficult to use AECs on pediatric patients, so consider setting techniques. Grid selection, keep in mind we want to keep the patient's dose as low as possible. So some of your pediatric departments will utilize for grids like 5-to-1 grid as opposed to a 8-to-1 or a 10-to-1 for adults. And keep in mind how thin they are. In a lot of cases, the likelihood of seeing external artifacts are even greater with pediatric patients and asthenic adults than what they are with most adults. So with obese patients, consider personal safety, consider the patient's ability, consider equipment limitations. Keep in mind that primarily what we're shooting through there is adipose tissue, so avoid the temptation to just increase your KVP. Grid use becomes more important, as does collimation. And I want to step back up here to personal safety. What I'm referring to here is not only patient safety, you don't want to drop a patient, but take care of yourself as well. We get a lot of our graduates that over the years just kind of abuse their body, picking up patients and moving them around. Have the patient do as much as they can and save yourself. Don't feel like you've got to pick up every patient and move them or push them around, and have the patient participate as much as they can. Take care of your own body. Explain what it is that you're doing what you need the patient to do, and enlist their help. So radiation protection, really the general principles haven't changed over the years. And CR systems consider that our screens or our imaging plates are slower than what they were in screens of films. So we used to increase KVP. We talked about the difference in contrast or how that affected contrast. Really not so much. We also talked about technique creep, or what we call dose creep. And that is to resist the temptation to shoot everything hot and have the system manipulate out the overexposure. Annotation, that's what that is. Make sure you mark your images. Quantum model should be pretty obvious. You get that speckly appearance. Generally indicates that you got inadequate mass. Also out here, we've got quantum model as well.